Welcome to a podcast brought to you by the American Academy of Orthopaedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
In today's must-listen episode of our podcast, we continue to highlight speakers from our recent conference. Today I have with me three guests. We start out the discussion with Dr. Lindsey Hughey and Dr. Glenn Thompson, and later Dr. Christina Myers joins us. They all participated in a presentation titled Implement Therapeutic Alliance Assessment to Redefine Your Patient's Musculoskeletal Health. A little bit about our guests. Dr. Christina Myers is a Director of Continuing Education and an instructor with Upstream Rehab Institute's Orthopaedic Physical Therapy Residency, OMPT Fellowship, and Continuing Education programs. She is currently pursuing a Doctor of Science in Physical Therapy at Bellin College, where she is researching the correlation between therapeutic alliance and outcomes, is board-certified clinical specialist in orthopedic physical therapy. Dr. Myers is adjunct faculty for the Doctor of Physical Therapy program at South College in Knoxville, Tennessee. Dr. Lindsey Hughey is board-certified orthopedic clinical specialist and a fellow of the American Academy of Orthopaedic Manual Physical Therapists. Dr. Hughey serves as an assistant professor at South DPT and runs part-time out of network private practice drivePT, where she treats mainly CrossFit athletes in chronic pain. She is an active member of the APTA and AAOMPT. And Dr. Glenn Thompson graduated from East Tennessee State University with a Bachelor's of Science in Physical Therapy in 1999. He graduated from Evidence in Motion with a Doctorate in Physical Therapy in 2014, board certified in orthopedics since 2017, achieved fellowship status in 2017, currently enrolled at Bellin College Doctor of Science in Physical Therapy. Well, let's jump right into our conversation. Dr. Thompson and Dr. Hughey, welcome to the podcast. I'm excited to have you join me today.
Thank you very much.
Thank you so much, Becca. We're excited to be here.
We're going to talk about the lecture that you gave at the virtual AAOMPT conference. And to get us rolling, can you give us a little bit of how this topic came to fruition and how you and your colleagues got interested in this?
Of course. Our topic was born actually from our research project that we're pursuing through Bellin College. So Chris, Glenn, and I are all in the DSC program there, and we're working on looking at what's called an exploration of therapeutic alliance in patients seeking care for musculoskeletal pain, qualitative and quantitative approach. So we're doing a mixed methods research project where we're recording the initial evaluations of therapists and their patients in the Bellin healthcare system. And what we're going to do is actually transcribe and view each video and look for behaviors in both word and action of what illustrates therapeutic alliance or helps build it, or possibly what behaviors help break it down. And we're going to look at if that has any correlation to filling out the working alliance inventory, which Glenn will speak to more later, but that there's a therapist version and a patient version, and you basically rate your level of trust and collaboration with the therapist as the patient, and then the patient's view of the therapist. So it's a really cool project. We're excited and currently enrolling patients and recording videos. So we don't quite know the outcome of it yet, but it really made us dive into more about measuring working alliance and being held more accountable to do that in the clinic.
This sounds really interesting. It's a subjective topic in a lot of ways, so trying to put some objectivity behind a sense or feeling that people have. Can you tell us a little bit more about therapeutic alliance and why it is important to the outcomes in physical therapy? Maybe give us a little bit of the research in that area.
Sure. And I'm sure Glenn will want to chime in here too. So anything that I missed, there is a plethora of literature concerning strong therapeutic alliance being equated to better outcomes. And it really originated in the psychological literature first, and then has kind of gradually trickled into the physical therapy literature because we have so much more time with our patients than a lot of healthcare practitioners. So we have that time to create that sense of collaboration, warmth, and support between our client and us. And so what we don't know, though, is what are some solid behaviors or words, phrases, body language that directly correlates with stronger therapeutic alliance. And there's some things suggested, like cognitive behavioral therapy, motivational interviewing, using strategies such as open-ended questions versus closed-ended questions. But we really are pursuing this project because we want to nail down some specific behaviors and maybe phrases that really help build therapeutic alliance. And you're right that it is very subjective. And so the WAI allows an objective sense there, but there still will be some qualitative aspects that I think our study will be able to illustrate that better, because this isn't a straightforward project. It's gray, just like the world of physical therapy, right? There's not pure black and white. We're excited to just explore what this means for our profession and maybe its incorporation into DPT education early, if we can really nail down what those behaviors look like.
So even though we don't have a lot of concrete evidence, can you still give us some of the characteristics that we believe tend to facilitate therapeutic alliance?
There was a great systematic review put out in 2018 concerning therapeutic alliance. Kinney et al. Did that, the impact of therapeutic alliance in physical therapy for chronic musculoskeletal pain, because this is where we're really seeing it be impactful in those with chronic pain, in those that need that cognitive behavioral therapy approach. Some characteristics we have identified both in the psychological literature and in physical therapy is some characteristics like being flexible as the therapist, being honest, being respectful, listening, not interrupting, instilling confidence in not only you as the provider, but in your ability to help the patient. So proxy efficacy, that being very strong. And then just the overall sense of warmth and openness. And they have proven that, and you see it every day in the clinic anecdotally, that person that is just a great people person, their outcomes tend to be awesome, even if they're not really doing all the evidence-based care, versus the person that is very rigid, not very warm, that is doing everything that's right as per the evidence, but not really building that relationship and trust.
Yes, there definitely seems to be some real importance to your ability to display empathy, and people need to feel cared for. So that's one of the big things I've read in the research, is how people feel around you, if they feel cared for and if they feel like they can trust you. And that'll impact the outcomes in some real simple ways of just being willing to follow your instructions.
That for sure. And that even came up in the discussion when we were doing our presentation virtually, was just that it really is a sense of trust, like you're building trust and trying to quantify trust, which I think is that gray area, right? Like, how do you really do that? Because every patient's a little bit different in what they need and the education they need to kind of change their narrative for the better.
It's kind of interesting. We go back to our fellowship training, and one of our mentors quickly told us, Barb Stevens, I'll never forget, said, patients don't want to know how much you know. They want to know how much you care. And in this study, we are able to use little tricks and little things that we see in the individuals just in their presentation toward the patient, that we think we can make a big impact in showing how much we do care and how much that can impact the patient's outcome.
Well, that's a nice segue. You have a slide in your presentation where you have 3 next steps. It looks like you're going to go into a little bit of how we can build our own ability to build therapeutic alliance. Can you elaborate on that and give us some of those steps that might help us?
One of the values of actually using the WAI, the Working Alliance Inventory, is that it gives you an opportunity as the therapist to self-reflect not only on your own communication strategies and the possibility that maybe you're not reaching your patient like you thought you were, or you're not on the same page in regards to goals. And then it allows an opportunity to just sit down with the patient. And it is a really vulnerable moment to be like, we're not actually matching up. I don't see our goals being the same. Let's talk about this. So it allows an opportunity not only for you to self-reflect personally, but then on that collaborative unit, you can self-reflect, are we headed as a team in the right direction? And then it allows you to pivot and change accordingly. It's just like a reevaluation. It's, are things going the way intended? Are we meeting our goals? If not, we need to change something. And, as it relates to Therapeutic Alliance, often it's something in the relationship or the way goals or the plan of care is being discussed. And then, that second step is embodied in kind of what I already talked about, is just inquire about Therapeutic Alliance. Take the time to do it. It is an extra paper, and patients have enough paperwork, and that part is hard. So you kind of have to sell it, either your front desk or you, the importance of actually taking the time to rate Therapeutic Alliance and talk about it. And then our third idea is that this will translate into communication skill training that is actually embedded in DPT education. And so right now it's very implicit learning, meaning you just learn it along the way. You learn it on your affiliations. It's embedded throughout curriculums in DPT education, rather than, a set 1 to 3 credit course where you're really looking to model those behaviors of motivational interviewing and using your body language to lean in versus sitting back in a chair, and learning what good alliance looks like versus poor alliance, and really making those skills be more explicitly practiced.
Since we're talking about the Working Alliance inventory as part of that self-reflection, can you give us a little bit more insight on what that form is, the different categories that form tries to rate you in, and functionally some of the questions, so we have an understanding of what this form's about?
Not a problem. The Working Alliance inventory was created by the Horvath Group back in 1989. That was the original form, and since that time, it's been, as many other things, been changed, and it's been reduced to make it more of a short form. I think the original form actually had 36 items, and now the short form has been reduced down to 12. It's less burdensome, and it's actually more appropriate for the clinic. But there are 3 domains that the Alliance inventory takes a look at, and those domains are the goal, the task, and the bond of the patient to the therapist. Now, keep in mind, you're dealing with the word therapist in this inventory is still looking more at the psychotherapeutic side of things. So when you look at goal measures, this is looking at the agreement between the patient and the therapist on the goals of their treatment. Are their goals in line with one another? Does the therapist see function-based, or is the patient looking at more pain-based goals? So things of that nature, are they in relation to one another, and do they agree there? Task-oriented goals, they're looking at, are the tasks or the treatments that we are performing for the patient, do they see that being a segue into them achieving those goals as far as the goal section? And the bond is more about that relationship. Is there a genuine relationship between the therapist and the patient? And the questions between the 2 forms are very, very similar, but things are, I guess the easiest way to put it, things are rated a little different. For in some cases where a patient sees a goal, the therapist may see that as a task. So the answers are from the bond, the goal, and the task are a little different between the therapist and the patient forms, but the questions are very, very similar to one another. Some of the questions that you'd be asked, for instance, one is blank, meaning the patient and I collaborate on setting goals for my therapy. And the patient and I are working towards mutually agreed upon goals. Those are some of the items in the goal section. And in the task section, one of the questions that's asked, as a result of this session, I am clearer as to how I might be able to change. And another question would be, what I am doing in therapy gives me new ways of looking at my problem. And finally, a couple examples of bond items is, I believe blank likes me, such as I believe my therapist likes me, and blank and I respect each other, or the therapist and I respect each other. They're quick, they're simple, there's 12 simple questions to answer. on a 5-point Likert scale, and you should take any more than between 5 to 10 minutes to answer that particular form. The therapist would do something quite similar, actually, and they could look at these two data points, look at how the patient perceives the session, look at how you perceive that session, and see where the differences lie, and get with that patient and use those as personal benchmarks on how to improve.
We actually have Dr. Chris Myers with us now too. Do you have anything to add, Chris, to that?
The only thing I would add to looking at the WAISR and the WAISRT is maybe just to outline just some of the mechanics. When we look at the scores, obviously the higher scores are correlated with better therapeutic alliance. But thinking about some of the psychometric properties, there is a fairly high internal consistency in these measures. And they've also shown high reliability in studies as well. And then on the validity aspect, the WAISR correlates well with other therapeutic alliance measures that have been used more in the psychotherapy world. So we know that we can use it and feel confident in what we are measuring. Can we do it reliably and accurately? Higher scores on the WAISR are associated with better outcomes. And statistically, from an analysis standpoint, the goal and the task can be typically very highly correlated with each other. And therefore, we recommend using the overall WAISR mean rather than the 3 subscales as standalone.
Excellent. After listening to your lecture at the virtual conference, I downloaded the forms and was looking at them and contemplating them. And they really have some great questions on there for that self-reflection that you'd mentioned as a way of improving therapeutic alliance. I didn't give them to any of my patients yet, but just simply reading through the questions and asking myself if I was doing this with my patients was just a really great reminder on those behaviors that we know we should be doing, but sometimes aren't as conscious of getting them done. So the rest of the afternoon with all of my patients, I was thinking through those, like, am I asking the patients about their goals and asking if this was working for them, or if they had any further ideas or things that they wanted to pursue, and really giving them some space and the freedom to engage more as an active participant in their therapy and making sure that they felt heard. So I really appreciated some of those suggestions on self-reflection and access to the form. I think it's going to be a great tool for me to get some real intentional building of my own therapeutic alliance. So thank you for that. And you guys have the checklist. Can you tell us a little bit more about that?
Of course, we will selfishly talk about this original checklist we have created. And I joke about the selfish because it's, our original creation, and we actually are hoping in the future it'd be something that other therapists utilize for self-reflection, kind of like what you were talking about, where it gives you a little self-awareness. So just looking at those WAI questions, you felt more aware, it changed your questioning. And so we created a list based on the evidence of things that have been correlated to higher therapeutic alliance, and kind of put them all in one. And so the checklist, the Myers-Thompson Hughey Therapeutic Alliance checklist, starts out with just talking about almost like it's an information gathering space. So how do we gather information? And it allows you to look at how many open-ended questions am I using in an eval? Am I pausing to listen? And obviously this requires you recording your eval to take some time to reflect, but you could also reflect at the end of a subjective interview or at the end of the total eval to say, did I actually do these things, or was I kind of rushing through, asking close-ended questions to get through the process? And then patient facilitating, like, do we intentionally use transition and conversational links to guide the interview? Or again, are we interrupting, or are we rushing the whole process? Or are we demonstrating that we intentionally are listening with connectors? Or are we asking a very random question? Because a very well done subjective interview really asks that next best question is very focused, which means your brain is all in as the therapist, really attentive to the patient before you. And then there's a category about interpersonal. So, was empathy exhibited? Did you demonstrate care or humor? Because those things really help humanize the experience for the patient and for you in developing that rapport and trust. And then some other categories, we don't have to go through all the details of each, but we touch on patient involving, so like asking clarifying questions, the use of body language to strengthen the alliance, like eye contact, leaning in, are your arms crossed, or are they by your side? Is there a computer in front of you? Did you take the time to shake hands with that patient? And then patient supporting, patient education, and then some things we talked about earlier, like goal setting and discussion. Did that actually occur? Was it collaborative? And then a category, the final three are language. Did you use patient-friendly language? Was there evidence of agreement in the treatment plan of care? And did you assess that the patient understood the overall care? And then you finally note any breakdowns in therapeutic alliance and ways that you made the patient the center of care.
That's amazing overview, Lindsey. And the only thing I wanted to add is that one of the intentions of designing this is that it could be utilized possibly for qualitative research purposes. It's a nice way of identifying themes and providing coding of those themes to allow us to track and hopefully consistently provide feedback on performance, whether used in entry-level education or post-professional and, of course, research purposes as well. So we hope that it's going to be utilized and that people will be willing to take it and use it and fine-tune it as well.
In your current research that you mentioned at the beginning of our conversation, are you to the point where you're actually using this with entry-level students?
Not at this moment. Right now, we're still gathering data from a variety of therapists in the Bellin College system to allow us to view the interactions between therapist and patient. So right now, I would say this is more of in an infancy stage before we've started interacting this into a more solid curriculum.
It'll be great to watch this unfold and see how it works its way into entry-level curriculum, because it's certainly an important topic, and we probably just assume that based on who we admit into PT school, there's some base level of emotional intelligence and ability to interact with people, but I don't know that it is something that's overtly taught at this point.
We're really excited at the prospect of using it in curriculum and to see how that changes. We do recognize that there'll probably have to be an initial pilot phase, but we do want to see what happens through this research first.
Is there anything else that you'd like to add that we didn't touch on about your project or the lecture you gave at the IOMP conference?
I think besides the encouragement, just like you did, Becca, to download the form, take a look at it, even just integrating a couple of those questions, whether you ask them out loud or not, for your practice to see, are goals collaborative? Are you meeting the patient where they're at? Because I think you'll see changes in the way you practice and ask questions pretty right away, basically. You'll see those changes.
Yeah, I second that. It was a good reflective process. Absolutely.
Becca, I would just add that in our ongoing research right now, doing our mixed method study through Bellin College DSC and utilizing active providers who are participating, we are excited that they've been able to utilize it consistently. They've been able to follow through, and we are really interested to see what their take is on use of it, because several of them will have used it multiple times throughout our research project. So again, it'll be really interesting to see and get their perspective on what they thought was valuable.
It'll be really cool. We hope to build off of this study and to have that be a secondary analysis, right, where we look and interview them. I think we'll get some good data that we weren't even looking for in the beginning.
Very good. Well, it's been a real great experience to have you guys come on the podcast and learn a little bit more about what you're studying, and also be encouraged to improve my own abilities in therapeutic alliance. Thank you, Dr. Thompson, Dr. Hughey, and Dr. Myers. And thank you so much for presenting at the American Academy Conference, and we look forward to hopefully seeing you at some of our next conferences.
Thank you so much for taking the time to talk with us today.
Thank you, Becca, for the opportunity. Appreciate it.
Thanks so much, Becca.
This has been a production of the American Academy of Orthopaedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.